Welcome to this lecture on glaucoma, based on Chapter 1 of the Basic and Clinical Science course, or BCSC series. In this session, we'll cover the fundamental anatomy, pathophysiology, and classification of glaucoma to help you build a solid foundation for further study. Glaucomas are classified by several key factors: etiology, whether they are primary or secondary, the configuration of the anterior chamber angle, either open or closed, which is determined by gonioscopy, and the age at onset, distinguishing between childhood and adult forms. Elevated intraocular pressure, or IOP, is a major risk factor for primary open-angle glaucoma. However, many patients with POAG have IOPs within the normal range. Globally, glaucoma is the leading cause of irreversible blindness. Genetically, single-gene forms are rare. Most glaucomas are influenced by multiple genomic regions that vary by type. Glaucoma is defined as an optic neuropathy characterized by excavation of the optic nerve head, also known as cupping, and the loss of retinal ganglion cells, or RGCs. Understanding the anatomical structure of the optic nerve is crucial in both diagnosing and monitoring disease progression. The optic nerve is composed of several key elements: axons of the retinal ganglion cells, glial support tissue, extracellular matrix, and blood vessels. A typical human optic nerve contains about 1.2 to 1.5 million RGC axons. The cell bodies of these ganglion cells reside in the ganglion cell layer of the retina, and their axons travel through the optic nerve to synapse in the lateral geniculate nucleus of the brain. The optic disc, or optic nerve head, typically measures between 1.5 and 1.7 millimeters in diameter, although this can vary by individual and ethnicity. As the optic nerve exits the globe, it expands to 3 to 4 millimeters in diameter due to axonal myelination, the presence of glial tissue, and surrounding connective tissue layers known as the leptomeninges. Within the nerve, axons are grouped into fascicles, which are separated by astrocyte-filled spaces that help support and insulate the fibers.
Nerve fiber entry and glaucoma susceptibility. Retinal nerve fibers enter the optic nerve head primarily at the superior and inferior poles. These regions are structurally more vulnerable to glaucomatous damage because they contain larger lamina cribrosa pores, which offer less resistance to pressure-induced stress. This anatomical feature explains why arcuate field defects are commonly seen in glaucoma. They correspond to damage in these structurally weaker regions. Figure 1-1. This illustration shows the anatomical pathways of nerve fibers entering the optic nerve head. Temporal fibers arch above and below the horizontal raphe. Nasomacular fibers take a straight path to the optic nerve head. The papillomacular bundle, which carries fibers from the nasal macula, enters the central part of the ONH. Peripheral fibers are positioned more externally, while central fibers lie closer to the core. Note that the fovea is usually situated just below the horizontal meridian, though its position can vary between individuals. Intraocular optic nerve regions. The intraocular portion of the optic nerve is divided into two parts by the lamina cribrosa. The anterior region, which contains unmyelinated axons. The posterior region, where axons become myelinated. The lamina cribrosa itself is a fenestrated collagenous structure that is continuous with the sclera. It provides a pathway for the axons to exit the eye. Also important is the superficial nerve fiber layer, or NFL, which acts as a transition zone for retinal ganglion cell axons as they enter the optic nerve head. Lamina cribrosa, structure. The lamina cribrosa is the primary structural support for the optic nerve as it exits the eye. It is composed of collagen beams, extracellular matrix proteins like elastin, laminin, and fibronectin, and also contains capillaries to nourish the passing axons. The pores are often visible at the base of the optic cup. Surrounding this structure is the ring of Elschnig, a band of connective tissue that forms a rim around the base of the optic nerve head. This ring connects the optic nerve to both the choroid and the sclera and is visible during clinical examination. Lamina cribrosa, vulnerability. The lamina cribrosa is not uniformly strong. Its larger pores in the superior and inferior regions make these zones more susceptible to glaucomatous damage. Furthermore, these regions have lower connective tissue density, which translates to weaker structural support. These anatomical vulnerabilities explain why glaucomatous optic nerve damage often follows a predictable pattern, particularly arcuate defects seen in visual field testing.
Figure 1.2, lamina cribrosa structure. The lamina cribrosa is a mesh-like network made of connective tissue beams. These beams create a scaffold that supports axons as they exit the eye. The slide shows two images. On the left, a 3D reconstruction of its fenestrated structure. On the right, a scanning electron microscope image after digestion revealing the openings for central retinal vessels. Again, take note of the larger pores in the superior and inferior regions, which increase vulnerability to glaucomatous damage. Blood supply to anterior optic nerve. 4 regions. The anterior optic nerve is divided into 4 anatomical regions: the superficial nerve fiber layer, the prelaminar, the laminar, and the retrolaminar regions. Each region has a distinct vascular source and configuration, which we'll explore in the next few slides. Arterial supply to the optic nerve. Overview. The posterior ciliary arteries, or PCAs, branches of the ophthalmic artery, are the primary blood supply to the optic nerve. Each eye typically receives 2 to 4 short PCAs, which further branch into 10 to 20 short posterior ciliary arteries. The circle of Zinn-Haller, although inconsistent, may also contribute. It forms a discontinuous arterial circle around the optic nerve within the sclera. The central retinal artery, or CRA, enters the optic nerve about 10 to 15 millimeters posterior to the globe, but it contributes only minimally to the anterior optic nerve. Regional blood supply. Details. Here's a more detailed breakdown. The nerve fiber layer is supplied by recurrent retinal arterioles from the central retinal artery. The prelaminar region is nourished by short PCAs, with possible contribution from the circle of Zinn-Haller. The laminar region receives blood from either short PCAs or Zinn-Haller, supplying a capillary network embedded within the lamina cribrosa. The retrolaminar region is fed by short PCAs, pile arteries, and possibly branches of the CRA. All 4 layers contain rich, anatomically confluent capillary beds, ensuring robust perfusion under normal conditions. Venous drainage of the optic nerve. Venous outflow from the optic nerve is organized in a parallel fashion. The superficial nerve fiber layer drains through the retinal veins into the central retinal vein, or CRV. The prelaminar, laminar, and retrolaminar regions drain either through the CRV or through axial tributaries that feed into it. This balance between arterial supply and venous drainage is essential for maintaining axonal health, especially in a disease like glaucoma that affects optic nerve perfusion. Glaucoma is defined by structural changes in the optic nerve head, most notably cupping. The initial set of damage is often at the lamina cribrosa, particularly in the superior and inferior poles, where the tissue is most vulnerable. Importantly, retinal ganglion cell axon loss begins before any detectable visual field changes are observed. This underscores the importance of early structural assessment in glaucoma management. Lamina cribrosa and mechanical stress. The lamina cribrosa is considered a biomechanical weak point in the eye wall and is subjected to mechanical stress from two main forces: elevated intraocular pressure and cerebrospinal fluid pressure. The degree of stress experienced depends on individual eye anatomy, such as axial length, elasticity, and optic nerve head size, as well as genetic predisposition. This stress can trigger remodeling, compression, and eventually retinal ganglion cell axonal damage. Figure 1-4. This figure illustrates two key panels. Panel A, a diagram, shows focal notching of the inferior neuroretinal rim, visible laminar fenestrations due to thinning, cup enlargement, nasal vessel shift, and associated peripapillary atrophy. Panel B, a clinical photograph, confirms these findings in a real patient. The key takeaway here is that structural progression, such as rim thinning and cupping, can occur before visual field loss is detectable, reinforcing the role of structural imaging in early diagnosis. Lamina cribrosa remodeling in glaucoma. This slide further emphasizes the process of lamina cribrosa remodeling. In panel A, we compare a healthy eye to a glaucoma-damaged one. In glaucoma, the lamina appears thinner, posteriorly displaced, and the optic cup is enlarged, reflecting progressive excavation. In panel B, a clinical image reveals focal loss of the neuroretinal rim with visible laminar pores in the superior region. The clinical significance here is that remodeling of the lamina cribrosa contributes to the hallmark cupping of the optic nerve and the ongoing progression of glaucomatous damage. Molecular mechanisms of axon loss. At the molecular level, several mechanisms contribute to axonal degeneration in glaucoma: mechanical strain, energy mismatch, mitochondrial dysfunction, and neuroinflammation. These lead to a decrease in pro-survival factors such as BDNF and an increase in pro-degenerative signals, including DOK-MAP3K12 and SARM1. The end result is axon degeneration and apoptosis of retinal ganglion cells, which are central to vision loss in glaucoma.
RGC death and vision loss. The death of retinal ganglion cells, or RGCs, leads to the loss of visual signal transmission to the brain. While it's likely that central nervous system visual centers are also affected by this degeneration, the potential for their recovery remains uncertain. Importantly, RGC loss in other optic neuropathies may also lead to visual field changes, but these conditions lack the characteristic cupping and optic nerve excavation seen in glaucoma.
IOP in glaucoma. Elevated interocular pressure is a major risk factor, but it is not required for the diagnosis of glaucoma. In fact, about 1/3 of primary open-angle glaucoma patients in North America have normal interocular pressures. This phenomenon is particularly common in Asian populations. For example, around 90% of Japanese POAG patients present with normal IOPs.
It's important to distinguish between ocular hypertension and glaucoma. Ocular hypertension refers to elevated IOP without structural or functional damage, and therefore it does not qualify as glaucoma. A true diagnosis of glaucoma requires evidence of optic nerve head damage or visual field loss, not just pressure elevation. So we should avoid labeling patients as having glaucoma based on IOP alone.
Low versus high IOP glaucoma is still not well understood. Some patients suffer optic nerve damage even when their IOP is within the statistical normal range, indicating that this level of pressure may still be too high for their optic nerve. In most cases, lowering IOP slows disease progression,
but this strategy is not universally effective.
Open-angle glaucomas are divided into primary and secondary categories. Primary open-angle glaucoma includes typical PAOG with elevated IOP, normal tension glaucoma, and juvenile open-angle glaucoma. Secondary open-angle glaucomas are due to identifiable causes that block or damage the trabecular meshwork. These include pseudo-exfoliation syndrome, pigmentary glaucoma, trauma, corticosteroid-induced glaucoma, inflammation, tumors, and lens-related pathologies, among others. Careful differentiation between primary and secondary types is critical as it guides treatment strategies and helps define the target IOP for that individual.
Angle closure glaucomas are also classified into primary and secondary types. Primary angle closure includes several stages. Angle closure suspect, where 180 degrees or more of iridotrabecular contact is present, but without IOP elevation or optic nerve damage. Primary angle closure, when there is iridotrabecular contact with elevated IOP or peripheral anterior synechiae, but no optic nerve damage. Primary angle closure glaucoma, when there is evidence of glaucoma damage. Acute primary angle closure, a symptomatic IOP spike due to sudden closure, and plateau iris configuration or syndrome, where angle closure persists even after iridotomy. Secondary angle closures are divided into with pupillary block, such as phacomorphic glaucoma or synechiae-induced blockages, without pupillary block, involving anterior pulling, such as neovascular membranes, or posterior pushing mechanisms, such as tumors, inflammation, or lens issues.
Combined mechanism glaucoma, also known as mixed mechanism glaucoma, occurs when glaucoma damage persists despite prior treatment for angle closure. This is often seen after laser iridotomy or lens removal, where the angle may now appear open, but outflow resistance or IOP elevation continues. Accurate classification is important to ensure that treatment addresses both residual angle closure mechanisms and open-angle pathology.
In open-angle glaucoma, gonioscopy reveals an open angle without obstruction, but the optic nerve shows characteristic glaucoma damage. Primary open-angle glaucoma, or POAG, shows no visible cause of obstruction. In cases with elevated IOP, the blockage is usually at the trabecular meshwork, particularly the juxtacanalicular region or the inner wall of Schlemm's canal. Normal tension glaucoma is a subtype of POAG where damage occurs despite IOPs in the normal range. Secondary open-angle glaucoma involves a known structural cause, such as pigment dispersion, trauma, or pseudo-exfoliation. Proper classification is essential to determine the appropriate IOP target, as POAG can cause damage even at lower pressures. Angle closure glaucoma is caused by mechanical blockage of the trabecular meshwork by the peripheral iris, preventing aqueous outflow. It's categorized as primary, where no underlying disease causes the narrowing, secondary, where pathology like a tumor or lens abnormality is responsible. The primary subtypes include angle closure suspect, 180 degrees or more of iridotrabecular contact but no IOP rise, primary angle closure, ITC, with IOP elevation or PAS, primary angle closure glaucoma, PACG, ITC, IOP, or PAS, and glaucoma damage.
There are two main mechanisms of angle closure: pupillary block,
When aqueous humor becomes trapped behind the iris, it causes the iris to bow forward and block the trabecular meshwork, raising IOP. Non-pupillary block. The iris is pushed forward by an external factor, such as a tumor, membrane, or anterior rotation of the ciliary body. This is more common in secondary angle closures due to inflammation, retinal procedures like PRP, or tumors.
This slide illustrates two key scenarios in aqueous humor dynamics. Panel A shows normal flow. Aqueous humor is produced in the posterior chamber, flows through the pupil, and enters the anterior chamber. From there, it drains out of the eye via two pathways, the trabecular meshwork and Schlemm's canal, and the uveoscleral pathway. Panel B shows a pupillary block. Here, pressure builds up in the posterior chamber due to blockage at the pupil, which causes the iris to bow forward, narrowing or closing the angle, and ultimately leading to a rise in intraocular pressure.
Combined mechanism glaucoma refers to cases where glaucoma persists despite prior angle closure treatment, such as laser iridotomy or lens extraction. These patients continue to show elevated IOP or resistance to outflow even though the angles appear open and no peripheral anterior synechia are present. It's also seen in complex cases, such as neovascular glaucoma post-CRVO with underlying POAG, or cases combining inflammatory and steroid-induced mechanisms. Use of the term should be careful and precise to avoid confusion.
Glaucoma is the leading cause of irreversible blindness worldwide. As of 2020, it was estimated that 80 million people globally had glaucoma, with over 11 million suffering from bilateral blindness due to the disease. The global prevalence among individuals aged 40 to 80 years is approximately 3.5%. and this is expected to increase due to aging populations worldwide. This slide summarizes findings from major epidemiological studies. The Baltimore Eye Survey showed that POAG prevalence increased with age and was 4 to 5 times higher in Black individuals than white individuals. Over 50% of cases were undiagnosed. The Rotterdam study in Europeans reported a 10-year incidence of 2.8%. Again, with about half of cases going undetected. The Barbados Eye Study found a 7% prevalence in African Caribbean individuals aged 40 and above. The Lale study in Latinos reported a 4.7% prevalence and highlighted that 3/4 of POAG cases were undiagnosed. Finally, the Tajimi study in Japan showed a prevalence of 3.9%, with 90% of POAG cases having normal IOPs. The mean IOP was about 2 millimeters per mercury lower than in European populations.
Key risk factors for primary open-angle glaucoma include higher intraocular pressure, lower ocular perfusion pressure, older age, thin central corneal thickness, high myopia, race and ethnicity, and genetics, with a 3 to 22% lifetime risk in individuals who have a first-degree relative affected by the disease.
The primary risk factors for primary angle closure glaucoma, or PACG, include older age, race and ethnicity, with the highest prevalence in Inuit and East Asian populations, followed by white and lowest in African Americans. Female sex, which is consistently associated with higher prevalence. Hyperopia, or farsightedness, and a family history of angle closure, which increases individual risk.
Prevalence of PACG varies significantly by population. Inuit populations have the highest known prevalence, ranging from 2.5% to 4.8%. In Asia, the overall prevalence is around 1.1% for ages 40 to 80, but higher in East Asia. For example, in Guangzhou, China, prevalence is 1.5% in adults over 50, with 43% experiencing unilateral blindness.
The Tajimi study in Japan reported a 0.6% prevalence. In Europeans, PACG affects approximately 0.1 to 0.4%. In Africans, it ranges from 0.1 to 0.6%.
Genetics overview. Glaucoma genetics differ by age of onset and type. Early onset glaucomas may follow Mendelian inheritance, either autosomal dominant or recessive. Gene loci are designated as GLC1 for open-angle glaucoma, GLC2 for angle closure glaucoma, and GLC3 for congenital glaucoma. Discovered genes include GLC1A, GLC1B, GLC1C, and so on, named in order of discovery. In contrast, adult-onset POAG is rarely linked to single-gene mutations. It's considered polygenic and complex, with heritability estimates ranging from 0.3 to 0.8. Genome-wide association studies, or GWAS, and whole exome sequencing continue to aid in identifying these polygenic risk alleles.
Juvenile open-angle glaucoma presents before the age of 40 with open angles and no secondary causes. It is strongly linked to the MYOC gene located at the GLC1A locus. Autosomal dominant mutations in MYOC account for about 36% of JOAG cases and roughly 4% of all primary open-angle glaucoma cases.
Familial normal tension glaucoma, or NTG, is linked to genetic mutations in OPTN and TBK1. These cases typically present early and follow an autosomal dominant inheritance pattern. They make up about 2 to 3% of all NTG cases and are believed to involve defects in autophagy pathways, a cellular process important for maintaining neuronal health.
Primary congenital glaucoma, or PCG, has an incidence ranging from 1 in 1250 to 1 in 10,000, depending on the population. Up to 40% of cases are inherited. The most common gene implicated is CYP1B1, an autosomal recessive gene essential for proper trabecular meshwork development and function. Other genes involved include LTBP2, which encodes an ECM protein and is linked to syndromes like Weil-Marchesani and microspherophakia, TEC-TY2, and ANG1, which are involved in the development of Schlimm's canal. While many cases are sporadic, genetic testing can assist in early detection and risk stratification.
Axenfeld-Rieger syndrome involves developmental anomalies affecting both the eyes and other systemic tissues. It's associated with glaucoma and linked to mutations in the PITX2 and FOXC1 genes, which encode transcription factors. Aniridia is caused by mutations in the PAX6 gene and leads to iris hypoplasia and glaucoma. Sporadic forms often involve large deletions at chromosome 11p13, which may also affect the WT1 gene, increasing the risk of Weger, WAGR syndrome. Therefore, chromosome 11p13 testing and abdominal ultrasound are recommended in these cases.
Pseudoexfoliation syndrome is characterized by the abnormal deposition of fibrillar material, which accumulates on the lens capsule, iris, zonules, and trabecular meshwork. This leads to outflow obstruction, elevated IOP, and secondary open-angle glaucoma known as PXG. Risk factors include aging, cold climates, and genetic predispositions, notably LOXL1 gene variants.
This slide summarizes glaucoma-associated genes and their inheritance patterns.
MYOC is linked to juvenile open-angle glaucoma with autosomal dominant inheritance. OPTN, TBK1, and related genes are associated with normal tension glaucoma, also autosomal dominant. CYP1B1, LTBP2, TEK, and ANGPT1 are associated with primary congenital glaucoma. PITX2 and FOXC1 are seen in Axenfeld syndrome. PAX6 is associated with aniridia, and CYP1B1, FOXC1, and PITX2 are linked to Peters anomaly, which has mixed inheritance patterns.
Genetic testing plays an important role, especially in early-onset glaucoma and ocular developmental anomalies with a high genetic burden. Applications include identifying inheritance patterns, detecting at-risk children early, estimating risk for offspring, and guiding potential future gene therapy approaches. For adult-onset POAG, GWAS-based genotyping may help predict disease progression, but its clinical utility remains limited and not yet routine.
While genetics are important, twin studies show that glaucoma is not purely genetic. Key environmental and behavioral risk factors include sun exposure, cold temperatures, especially relevant to pseudo-exfoliation, estrogen levels, cholesterol and statin use, and lead exposure. Protective factors include regular exercise, a healthy diet rich in green leafy vegetables, and avoiding air pollutants. These modifiable factors offer opportunities for preventative strategies in glaucoma care.